Imagine the most nerve-dense, highly sensitive square inch of the human body.
Right.
Now imagine injecting it with a needle.
Yeah, that's a lot.
Your brain is probably already screaming no,
Right.
right?
Yeah.
Just the mere thought of a needle approaching that kind of incredibly sensitive tissue is enough to make anyone completely wince.
Oh, absolutely.
But what if I told you medical science has figured out like a biological cheat code, a way to make that exact procedure feel like absolutely nothing?
It sounds impossible, but it's true.
It's wild. Welcome to today's deep dive. We are looking at a landscape where clinicians can literally bypass the body's most sensitive alarm systems. And, our mission today for you listening is to figure out exactly how they do it.
It's a fascinating process.
We are exploring this highly specific, multi-layered anesthetic protocol used to make a notoriously sensitive medical procedure, clitoral glands, platelet-rich plasma infiltration, manageable, comfortable, and for some, virtually painless.
Yeah, and it's a profound shift in how we approach delicate anatomy. For decades, there was this underlying assumption in certain areas of medicine that accessing the body's most delicate tissues had to be, on some level, just an agonizing process.
You just squeeze the armrests and deal with it.
Exactly, you just grit your teeth. But this protocol completely flips that on its head. We literally have to outsmart human anatomy to get the healing agents where they need to go.
And for you listening, to understand how they pull off this anatomical heist, basically, we pulled together a really fascinating stack of material for this deep dive.
We've got a lot of good sources today.
Yeah, we've got FDA prescribing information for topical anesthetics, clinical guidelines, medical protocols for pelvic nerve blocks, along with the actual procedures for regenerative PRP treatments. You might occasionally hear that referred to as the O-shot.
Right.
We're going to put all the source material on the table at once today, because the real marvel here isn't just the regenerative treatment itself, as groundbreaking as that is.
It's the delivery.
Yes. It's the precision required to deliver it without the patient, jumping off the table.
That is the core of this entire discussion, really. The procedure is conceptually brilliant, but it is entirely useless if the patient cannot tolerate it.
Right.
I mean, you cannot administer a regenerative therapy if the nervous system won't even allow you in the front door.
Exactly. And I want to get to the stealth tactics of the anesthesia, but I feel like we need to establish the stakes first.
Sure.
Why are we injecting platelet-rich plasma, or PRP, into the clitoris to begin with? I mean, to an outsider, it sounds a little extreme.
Well, it starts with the patient's own biology. The foundation of this procedure involves drawing a very small amount of the patient's blood.
Like how small?
We are talking about less than 10 cc, which is essentially just 2 teaspoons.
Oh, wow. Okay, that is small.
Very small. And that blood sample is placed into a specialized centrifuge.
Yeah, I'm looking at the centrifuge protocol, and it feels a bit like panning for biological gold.
That's a good way to put it.
You are spinning this blood so incredibly hard that the heavy red blood cells just sink to the bottom, leaving this liquid gold, the platelets floating right on top.
That is a highly accurate way to look at it, yeah? You are isolating the body's first responders. Platelets are the cells responsible for healing.
Okay.
Think about when you get a cut on your finger. Platelets are the cells that immediately rush to the site to clot the blood.
Right, to form a scab.
Exactly, but their job doesn't stop at stopping the bleeding. They also release these really powerful growth factors and cytokines.
What are those exactly?
They're basically signaling proteins. They essentially shout out to the local stem cells, telling them to come to the area and start repairing and rebuilding the tissue.
So you are basically taking the body's natural healing crew, pulling them out of general circulation, and concentrating them into a single, highly potent syringe.
Yes. And from a clinical application standpoint, this concentrated PRP is then injected directly into the clitoral glands and about 1 inch deep into the anterior vaginal wall.
1 inch deep. That sounds intense.
It is a very specific physiological area called the submucosal or suburethral space. And when injected into those precise locations, those platelets release their growth factors.
And that triggers the healing.
Right. It stimulates angiogenesis, which is the creation of new blood vessels, bringing fresh blood flow. It also stimulates the growth of new connective tissue and even new nerve cells.
Which has, massive implications for quality of life.
Yeah.
The clinical applications listed in the sources here are no joke.
No, there are life-altering conditions. This regenerative process is used to treat female orgasmic disorder, urinary incontinence, and dyspareunia.
Which is chronic, painful sex, right?
Yes, exactly. It is also used to treat chronic autoimmune conditions like lichen sclerosis.
Let's actually pause on lichen sclerosis for a second, because the physiological changes it causes really highlight why this treatment matters. It causes severe scarring, right?
Severe scarring, intense itching, and a dramatic thinning of the genital tissue. Over time, the tissue can essentially fuse together. Or it tears very easily because it loses all of its elasticity and blood supply. So by injecting PRP into that compromised area, clinicians are delivering a concentrated dose of regenerative signals to try and rebuild that damaged, under-functioning tissue from the inside out.
Okay, so the biological intent is amazing, but I have to stop us here.
Okay.
I am raising a massive red flag on behalf of anyone listening who is visualizing this right now.
Yeah.
You are talking about taking a needle and injecting it into the clitoris.
I know, it sounds...
Anatomically speaking, this is quite literally the most nerve-dense area of the human body.
Yeah.
We are talking about thousands of microscopic nerve endings packed into a tiny structure.
Yes, absolutely.
A needle going in there, the patient would jump off the table and run out the door. I mean, how is it physically possible to even approach this?
The hesitation is completely warranted. If a clinician just walked up with a needle and no preparation, the pain would be intolerable.
Right.
You are dealing with an evolutionary alarm system that is specifically designed to protect highly sensitive reproductive anatomy. To bypass that, the solution requires a highly orchestrated, multimodal approach.
Meaning you can't just use one method.
Exactly. You cannot rely on a single trick. You have to shut down the nervous system in layers, starting at the absolute surface.
Which brings us to the first layer of defense. The protocol heavily relies on a topical cream called EMLA.
Right. EMLA.
Let's talk about the mechanics of this, because I'm looking at the chemistry in the FDA info, and this isn't just like an over-the-counter numbing gel you'd find at the drugstore.
Not at all. EMLA is a specific pharmacological tool. The acronym stands for eutectic mixture of local analgesics.
Okay.
The magic of this medication really lies in the word eutectic. It is an oil and water emulsion combining 2.5% lidocaine and 2.5% prelocaine.
Now, lidocaine is standard, right? You hear about that at the dentist.
Mm.
But what does the eutectic part actually do?
It actually changes the physical state of the medication.
Really?
Yeah. Normally, lidocaine and prelocaine at room temperature are solid microscopic crystals.
Oh, weird. So they're like tiny rocks.
Basically, yeah. But when they are combined in this very specific eutectic ratio, their melting point drops significantly. This means that both anesthetics remain in a liquid state at room temperature.
I see. So instead of dealing with solid particles, you have a fluid. Lidocaine normally acts like microscopic jagged crystals, so they can't easily slip through the tight cellular mesh of human skin.
Exactly.
But by creating a eutectic mixture, you force those crystals to melt into a liquid at room temperature. Suddenly, instead of trying to push rocks through a chain link fence, you're just pouring water through it.
That is a phenomenal way to visualize it, honestly. Because it is in that liquid state, the active numbing agents penetrate the skin barrier far more effectively and in a much higher concentration.
Yeah.
They just flood the epidermis and dermis, rapidly silencing those surface-level pain receptors.
But the anatomy of where you apply this water through a fence mixture changes everything, right? Because the FDA prescribing information points out a really stark contrast between applying EMLA to a regular patch of skin versus the genital mucosa.
Oh, it's a completely different landscape.
Right.
The human body is covered in different types of protective barriers.
Right.
Think about the skin on your arm or your leg. It is covered in a tough, highly keratinized layer. Keratin acts almost like overlapping shingles on a roof. It is literally designed to keep moisture in and environmental hazards out.
Okay, that makes sense.
So if a clinician wants to use EMLA on that intact keratinized skin, say, for an IV insertion or a minor skin graft, they have to apply a huge, thick layer.
Just cake it on.
Yeah, and then cover it tightly with an occlusive dressing, like a plastic film, to trap the moisture. And then they have to wait a full 1 to 2 hours before the medication finally breaches the shingles to reach maximum effect.
Wait, 1 to 2 hours? Who has 2 hours to sit around in a clinic waiting for a cream to work?
Right, it's not practical for a quick procedure.
But when we move to the genital area, the rules completely change.
Entirely different rules. Genital mucous membranes do not have that tough, keratinized, shingled outer barrier. Mucosa is highly permeable. It absorbs compounds incredibly fast, more like a sponge than a roof. For minor procedures on the female external genitalia, the protocol dictates applying a thick layer, about 5 to 10 grams of EMLA, directly to the mucosa.
And because it's acting like a sponge rather than a shingled roof, the timing shrinks dramatically.
It only takes 5 to 10 minutes to take full effect.
That is so fast.
It really is. And because the mucosa absorbs the liquid eutectic mixture so readily, you don't even need that plastic occlusive dressing. That quick 5 to 10 minute application provides a solid 15 to 20 minutes of highly effective localized analgesia.
I did note in the medical protocols that some clinics use a compounded BLT cream as an alternative.
Right, yeah.
That's benzocaine, lidocaine, and tetracaine. But that one usually has to be left on for about an hour under a plastic wrap. So clinicians have options depending on their supply.
Exactly. They can adapt based on what they have.
But wait, if EMLA is just soaking into the surface level mucosa, it's not going to stop the pain of a needle going a full inch deep into the vaginal wall, right? It's only silencing the shallow receptors.
What's fascinating here is that you've just hit on the exact reason this is a multimodal protocol.
Oh, I see where this is going.
EMLA is incredibly effective for superficial pain, but its primary purpose in this specific regenerative procedure is to act as a pretreatment. EMLA is basically a Trojan horse.
Meaning it's just getting the door open for the heavy artillery.
Exactly. EMLA numbs the mucosa just enough so that the patient does not feel the next needle coming. To numb the deep structures of the clitoris and the anterior vaginal wall where that PRP actually needs to go, you cannot rely on surface absorption. You have to go to the neurological source. You need a deep regional nerve block.
Okay, so this requires a quick jump into neuroanatomy to understand how the clinicians actually pull this off. We need to talk about the pudendal nerve.
The pudendal nerve, yes.
If EMLA handles the shallow surface, the pudendal nerve block handles the deep structural pain. So where is this nerve, and why is it so critical?
Well, the pudendal nerve is basically the main sensory highway for the perineum.
Okay.
It originates way back at the base of your spine in an area called the sacral plexus. From there, it snakes its way down through the pelvis via a physiological tunnel called Alcock's Canal.
Alcock's Canal, got it.
And as it exits that tunnel, it divides into several branches.
And what territory do those branches cover?
They supply sensation to the perineum, the urethra, the pelvic floor sphincters, and crucially for this specific procedure, one of those branches becomes the dorsal nerve of the clitoris.
So it is the absolute epicenter for the exact area the needle needs to enter.
Yes, precisely.
So to block this highway, clinicians use what is called a transvaginal approach. Visualize this for us. How does a clinician safely access a nerve buried deep inside the pelvis?
While the patient is lying back, usually with their feet in stirrups, the provider performs a gentle internal exam, using their fingers to feel along the lateral vaginal wall. They are feeling for a very specific bony landmark called the ischial spine.
The ischial spine.
Right. It's a small bony protrusion inside the pelvis, and the pudendal nerve crosses right behind it.
Wait, so they are essentially using their fingers to map the pelvic bones through the vaginal wall, knowing that if they find the bone, they find the nerve hiding right behind it.
Precisely. It's all about anatomical landmarks. Once they locate that bony landmark, they utilize a highly specialized tool called an Iowa trumpet.
An Iowa trumpet. That sounds like a brass instrument from a marching band, not a surgical tool.
I know, it does sound musical, but it is actually a small, curved, tubular needle guide.
Oh, so it's a guide.
Yeah, it acts as a protective sheath. The clinician slides this guide along their finger inside the vagina. It protects the surrounding delicate vaginal tissue from getting snagged or punctured.
Right, because you don't want a stray needle in there.
Exactly, and it allows the clinician to safely direct the needle exactly to that target area near the ischial spine.
And this is where the stacking method comes into play, because the clinician applied that EMLA cream 10 minutes ago. The mucosal surface of the vaginal wall is completely numb.
Exactly.
So as that needle passes through the vaginal wall to reach the deep nerve,
The patient typically feels nothing more than a very minor pinch, or often just a strange sensation of pressure. The surface alarm system has been temporarily disabled.
wow,
So then the clinician injects a local anesthetic, typically a longer-lasting medication like ropivacaine or a fast-acting lidocaine, mixed directly into the space right next to the pudendal nerve trunk.
I see. So if the nervous system is like a high-tech security system,
Sure.
the EMLA cream is like quietly disabling the motion sensors on the front lawn. It lets you walk up to the house undetected.
I like that.
But the pudendal block, that's sneaking into the basement and completely shutting down the main breaker box for the entire property.
If we connect this to the bigger picture, that analogy is spot on. By blocking that specific nerve trunk at the ischial spine, you shut down the deep pain pathways before they can ever send a distress signal up the spinal cord to the brain.
You just cut them off at the source.
Right. You are providing profound regional anesthesia to the entire lower pelvic region. You aren't just unscrewing a light bulb, you've cut the main power.
Which sets the stage perfectly for the synergistic execution of the actual PRP infiltration. Let's walk through the step-by-step reality of how this all comes together for the patient in the room, because based on the clinical protocols we looked at, timing is everything.
Oh, timing is critical. It is a carefully orchestrated timeline. If you rush it or, do things out of order, the patient experiences pain.
Right. Okay, so step one. The clinician applies the topical numbing cream. They apply the EMLA for 5 to 10 minutes, or the BLT for an hour, directly to the clitoris and the front vaginal wall. The motion sensors are disabled.
Exactly. Then, step 2 happens concurrently. While that cream is sinking into mucosa, the blood is drawn from the patient's arm and spun in the centrifuge to isolate that liquid gold, the platelet-rich plasma.
Okay, then step 3. The clinician administers the deep local nerve block, the pudendal block with lidocaine or ropivacaine, using the Iowa Trumpet Guide.
Right.
The surface cream ensures this deep injection is virtually painless, and now the main breaker box is shut down.
And then there's one final, incredibly simple layer to this protocol that shouldn't be overlooked.
What's that?
Right before the actual PRP injection, the clinician applies a localized ice pack directly to the clitoris.
Ice. Really?
Okay.
After utilizing eutectic mixtures in deep pelvic nerve blocks, they use an ice pack. It feels almost primitive compared to everything else we just talked about.
I know, but never underestimate the power of thermal therapy. It provides an immediate additional layer of topical numbing, but more importantly, it utilizes thermal shock.
Thermal shock.
Yeah. When you introduce intense, sudden cold, you overwhelm the local sensory receptors. The body's neurological bandwidth is limited.
Oh, I see.
If the nerves are desperately trying to process the intense cold signal, they literally have less capacity to process a sudden pain signal. It distracts the remaining nerve endings.
That is so smart. So finally, with the area profoundly numb from the EMLA cream acting as the Trojan horse, the pudendal block cutting the deep power, and the ice pack chemically distracting whatever sensory bandwidth is left, the clinician uses a tiny needle to inject the PRP.
Yes.
About 4.5 cc's goes deep into the anterior vaginal wall, and a smaller, highly concentrated amount goes directly into the clitoral glands.
And it is vital to emphasize the reality of the patient experience here. Complete, absolute painlessness can never be unequivocally promised in any field of medicine.
Of course not.
Everyone's anatomy is unique. Nerves can branch in atypical ways, or a patient might metabolize anesthetics faster than normal. Clinicians are heavily advised in the protocols to establish a comfort plan with the patient beforehand and to pause the procedure immediately if unexpected pain occurs.
Right. That makes total sense. You can't guarantee a 100% pain-free experience for every single human body.
You can't. But because of this stacked protocol, a procedure that conceptually sounds agonizing, injecting a needle into thousands of dense nerve endings, is reduced to what most patients describe as just a momentary, tiny sensation of pressure.
It's torture.
Yeah. And the actual injection process of the PRP, it only lasts about 1 minute.
It is deeply ironic, but also brilliant. I want to linger on this for a second because it is such a fascinating medical paradox.
Oh, so?
Clinicians go through this intense, multi-step process. They melt crystals into liquids to breach the mucosa. They map internal bones to find deep nerve trunks. They use thermal shock. They go to extraordinary lengths to completely silence and shut down the body's nerve signals, all so they can inject growth factors designed to eventually wake up, stimulate, and regenerate those exact same nerves.
It really is the ultimate paradox of regenerative medicine, isn't it? We have to temporarily put the nervous system to sleep in order to feed it and heal it.
Yeah.
The main barrier to regeneration is the body's own protective pain response.
Which brings us to what you, listening, should really take away from all this. What we are looking at today is how combining topical EMLA with a deep pudendal nerve block turns an intimidating needle in the most sensitive place imaginable treatment
Right, quite literally.
into a highly manageable 30 to 40-minute in-office procedure. It is a literal masterclass in combining different medical tools, leveraging fast surface absorption and targeted regional anesthesia to completely outsmart the body's natural pain receptors.
And this raises an important question for us to mull over as we close.
Yeah, what's that?
Well, we've seen how this highly specific, stacked pain-blocking protocol successfully allows clinicians to inject a patient's own regenerative plasma into the most sensitive tissue in the human body. Could this exact stacking method of anesthesia, using targeted topical agents like eutectic mixtures as a gateway for deep regional blocks, eventually unlock our ability to comfortably perform other advanced regenerative therapies on highly nerve-dense, hard-to-treat areas of the body?
Oh, wow.
There are numerous treatments we currently avoid simply due to the anatomical barrier of pain.
Just imagine what we could heal, what kind of chronic conditions we could resolve if the fear of pain was completely removed from the medical equation.
It's a very promising frontier.
It really is.
Oh.
Thank you so much for joining us on this deep dive. Keep asking questions. Keep exploring the fascinating ways medical science adapts to the human body. And remember, the next time you think a procedure is going to make you squeeze the armrest, just know that science might have already found a biological cheat code to quietly pick the lock.